I think that the management depends upon what the woman's hepatitis B status is at the time of pregnancy. There are situations where women will present in pregnancy with hepatitis B and they will already meet guidelines for therapy at that particular time. However, for many women who are pregnant, they actually do not fit nicely into any of the treatment guidelines for hepatitis B infection. And so those are women that usually present in pregnancy without already being on hepatitis B treatment. If that is the case, at least in the United States, current guidance would suggest that if these women have elevated hepatitis B viral loads greater than 200,000 international units per milliliter, these women should be considered for prophylactic hepatitis B therapy across the time of their pregnancies. The time at which we typically start this is between the 28th and 32nd week of pregnancy, and the reason why we choose this time frame is because this is the time frame that has been best studied historically in research. There are opportunities for these women, though, to actually just remain on therapy for the time of their pregnancies with consideration for discontinuation of their therapy early postpartum, either at the time of delivery or within the first 3 months after delivery. But keep in mind, this is for women who did not already meet the guidelines for hepatitis B treatment prior to their pregnancies. That's a very interesting question, and actually there was an abstract presented at yesterday's presidential clinical plenary that actually looked at the use of hepatitis B treatment earlier in pregnancy, prophylactically, in the absence of hepatitis B immune globulin, which we would typically think about giving to our infants who are born to mothers with hepatitis B. So in that particular study that was presented by Dr. Calvin Pan, the goal was to figure out, could you reduce or stop mother-to-child transmission of hepatitis B by giving hepatitis B treatment earlier, prophylactic treatment that is earlier in the context of pregnancy, and then when the babies are born, rather than giving them immune globulin, you could just give them active immunoprophylaxis through vaccination. And what they found in that study is that indeed there was reduction in mother-to-child transmission with the use of earlier hepatitis B treatment, so earlier than that 28th to 32nd week. And in those infants who were born to those mothers with hepatitis B infection, even though they were not given immunoprophylaxis and they were only given hepatitis B vaccination, they did not go on to develop chronic hepatitis B infection. So this is interesting data that gives one example for why it might be beneficial to actually start this type of treatment earlier in pregnant women. More research studies, I think, are needed, but certainly these data are promising. So the general risk of mother-to-child transmission of hepatitis C in women who are mono-infected with hepatitis C is thought to be in the order of about 5 to 6%. However, that rate of transmission is actually doubled in the HIV hepatitis C co-infected population. So having co-infection with HIV can increase the risk of mother-to-child transmission. There are some more recent data that will be published, I believe this month, in the Journal of Hepatology that actually show that it may also be the degree of hepatitis C viral load that may actually contribute to an increased risk of mother-to-child transmission. So viral load may actually turn out to make a big difference in terms of the rates of transmission. Indeed, there is concern about whether or not it would be beneficial to actually treat these mothers with hepatitis C therapy during the context of their pregnancy in order to prevent mother-to-child transmission. Certainly, in the United States, it's important to consider this in regards to the fact that some women are going to be a more captive audience, more engaged in their health care in the context of pregnancy, and therefore that might be the best time to really think about instituting treatment. We need more studies to figure out whether or not there will be any concerns for safety of treatment of hepatitis C in the context of pregnancy. There has been some case report data. There is one small clinical trial that has looked at this, and through those data, it seems as though it's promising that we may be able to do this safely in this population. But again, we'll need more data. We don't have official approval of the use of the direct-acting antiviral agents for use in the context of pregnancy. What has been studied through one clinical trial that was actually registered in our National Clinical Trials Registry is the use of ladipavir sofosbuvir in the setting of pregnancy. The data from that study would suggest that it's probably safe for use. Certainly no significant adverse events have been seen thus far, but again, we need more research data.